myocardial infarction, then probably I'm just going to ask you some questions on myocardial infarction, and let's see how it goes. Simple questions, not technical questions. Okay. So when I say myocardial infarction, what are the things that come to your mind with respect to the management, or for that matter, what is myocardial infarction? What is actually occurring?
In myocardial infarction, there is plaque rupture. After that, there is deposition of fibrine.
So what Ashok is saying is that there is going to be a plaque rupture. There is going to be a plaque rupture. But is that the only way myocardial infarction occurs? Is that the only way that myocardial infarction occurs? Huh? Which are the other ways that myocardial infarction occurs?
With vasospasm.
Okay, vasospasm. Apart from that? Yeah, so what is that called as?
Imbalance
Demand and supply.
Yeah, so you have, largely you could divide myocardial infarction into two parts. One is the occlusive myocardial infarction. Occlusive myocardial infarction, that is because of some kind of physical obstruction to the blood supply. Right? That is occlusive myocardial infarction, and the other one is non-occlusive myocardial infarction. Vasospasm does not cause any of these, no? Because vasospasm is not causing infarction, it's causing angina. It's different. You understand? Angina is different. There is a pain because of reduction in blood supply, but it does not cause infarction. You are understanding? Huh? You are understanding? So when you say type of myocardial infarction, I would say occlusive, and you say non-occlusive. Right? Now, I will give you one more example of this. When occlusive is there, there could be type 1 and type 2. Now tell me what is type 1. Type 1 is what you said. Type 1 is what you said. That there is a plaque somewhere, and for some rhyme or reason, it's your fate that your plaque ruptured. When your plaque ruptured, it has gone and caused a drop in the circulation, and that has caused myocardial infarction. This patient has had a chest pain. That is type 1 MI. What is that called as type? In that MI, because there is a plaque obstruction, because a plaque has ruptured, what are you going to see? What is the clinical feature? Is it going to be sudden or is it going to be slow?
Sudden.
It's going to be sudden. You got the time limits. Is there going to be chest pain or no chest pain? There is 100% going to be chest pain, and that chest pain will be very typical because the plaque rupture has occurred here. Since the plaque rupture has occurred here, the heart is getting infarcted, so the chest pain becomes extremely typical. Extremely typical. What happens to your ECG?
Distillation.
Yeah, so because your plaque is rupturing, there is a part of the myocardium that is dying. You will have a transmural infarct, and when you have a transmural infarct, you may have changes in the ECG, which are ST segment elevations. Generally, right? Since there is a infarction and the entire myocardium is dead on that part, what else will get? What enzymes will go up? Cardiac enzymes will go up, but then after some time, what will happen to these cardiac enzymes? It will come down also, because it just can't stay on top. If it is staying on top, it means there is something more. It has to release, and then it has to go out of the body. It has to release, and it has to go out of the body. You're understanding? So there is going to be a dynamic change in your troponin levels, or high sensitivity troponin levels. There's going to be a dynamic change. You can't just have one troponin. You will have two troponin, which actually shows dynamicity, that it is going up or going down. You should have something like that there. Clear? It will go up and then it has to come down. You understand? So dynamic change. And because you've had a transmural infarct, your echo will show what? Regional wall motion abnormality. That means it will show you a wall motion abnormality in a specific region where there is a reduction in blood supply. So it can't be in say watershed zones, it can't be whole heart, it has to be in a specific region which actually supplied by a specific artery. So it could be either LCX, it could be LAD, or it could be RCA. Clear? Huh? So it has to be in the territory. So you can have LAD, you can have LCX, or you can have just RCLCX. RCLCX all together. Clear? So now you come to the definition of myocardial infarction. What is the definition? If you want to clinically, what is the clinical definition of myocardial infarction? Start from the first.
Sudden onset
Of. Sudden onset of. Sudden onset of typical chest pain. Then, out of the 5 things that I told you, one thing should be there. What are the 5 things I told you after that? So sudden onset typical chest pain has to be there. Okay, sudden onset, because it is a artery that is occluded. You can't not have anything. If you are going to have an artery that is occluded, there is going to be a typical sudden chest pain. That has to be there. Sudden typical chest pain. So my history should have that. Say that yes, he's got a sudden typical chest pain, to call it type 1 occlusive myocardial infarction. Sudden typical chest pain. Then out of the rest 5 things that I said, there has to be one. So what are the 5 things that is written? Tell me one. ECG changes. Okay, ECG changes that involves ST segment elevation of pathological Q waves. What the ECG change will be? ST segment elevation or pathological Q waves. And where ECG segment, what ST segment elevation? In the zones, in those particular territories. It can't be just diffuse. ECG chest pains in those zones, because it's one single artery that is getting occluded. You understand what I'm saying? So you can have it either in the hereditary territory, or it has to be the inferior wall, it has to be the lateral wall, it has to be the anterior wall. You should have a territorial ECG change. ST segment changes or pathological Q waves. So you got 2 criteria coming. So you can have either have the pathological Q wave, or you can have the ST segments that are elevated. Then drop by dynamic change in the troponins. You have to say dynamic. It cannot be troponin positive. It has to be dynamic change in troponins. Dynamic change. Okay. For example, we have that patient on bed number 12. Bed number 12. You had one troponin. You had second troponin. First troponin was, I think 5 or 6. I don't know what. 4 point something. And the second troponin is 9,000. So dynamic change. Understanding? Dynamic change. Right? Dynamic change. Then echocardiography showing RWMA. Then we finished 5. We finished. First one was no. That is has to be there. That has to be. That is not. Out of 5, you have ECG changes, which includes ST segment and pathological Q wave. Dynamic troponin change. RWMA. So 4 हो गया. These are the 4. Out of this, 1 should be there. Clear? Out of this, 1 should. Yeah, 1 should be there out of this. ठीक है? Then only we can call it as clinically as myocardial infarction. Right? Now this was type 1. This was type 1 occlusive MI. This was type 1 occlusive MI, where you said the pathophysiology was you have a plaque that is ruptured and that has caused territorial infarct. This is what we discussed. There's a plaque that is ruptured and that has caused territorial infarct. This is called as occlusive MI. The best MI to treat is this one. The best MI to treat is this one. The best MI that will cause improvement. मेरा अगर फैमिली में किसको हो गया, ये अगर हो गया है, बॉस इसको एंजियोग्राफी करो. समझ रहे? मेरा अगर फैमिली में किसको ऐसा हुआ है, इसको एंजियोग्राफी करो. I don't have to wait. इसके एंजियोग्राफी करो, जिसमें ऐसा कुछ है. Clear? इसमें एंजियोग्राफी करो, because this is the one that is going to cause cause improvement in mortality and major adverse cardiac events. This is the myocardial infarction of great interest to me. Type 1 occlusive myocardial infarction. If there is type 1, obviously there is type 2 also. So what do you think would be type 2 occlusive myocardial infarction? What do you think would be type 2? Come on. Does anybody want to help Ashok, or Ashok you want to think? So you said, so let's go to this once more. When you say myocardial infarction, we talked about occlusive myocardial infarction and non-occlusive myocardial infarction. Clear? Am I clear on this? When I say occlusion means there is a physical occlusion. There is a physical occlusion. So when I said physical occlusion and when Ashok started about physical occlusion, he said type 1 MI. And when you say type 1 MI, you classically said that this is a plaque rupture, which is absolutely right. Plaque rupture. And we said when you have plaque rupture, you may have few things which include sudden typical chest pain and then one of these things, that is echo, troponin, ECG, will be probably going to be there, right? So one of these things would be there: dynamic rise of troponin, ECG, and echo, right? Right. So there has to be a type 2. What is the type 2? So type 2 is a situation where you are having a plaque, you are having an occlusion. So here what has happened? Here there was a plaque which ruptured and created an occlusion, right? Now here what is happening is there is already a big plaque sitting over here somewhere. There is a big plaque sitting somewhere, already a big occlusion, already something that is narrowed the entire thing. And now you are in severe stress. And now you are in severe stress.
Demand is
okay, so your demand has increased. Since your demand has increased, this is fixed outlet. This is fixed outlet. You have started getting these things. These same things. You understand? With this, again the chest pain, again with all these things. But the difference is here the ST segments are not going to be elevated or cued. You understand? They are not elevated or cued. This is type 2.
So bendocardial.
Bendocardial. You understand? That is what which patient? The patient we just now discussed. We discussed this patient, right? The patient just now in bed number 12. Type 2. Troponin 5,000. I said, I didn't get scared, right? Because someone who called me in the night yesterday told me, who called me from here? Someone called me saying troponin is very elevated. No, someone called me. So troponin is very elevated. But does he go into fit these features? Does he fit this? Is this type 1 MI? Is the ST segment elevated? Is there pathological Q wave? No. Is there an echo demonstration that says regional hormone abnormality? No. Only thing we see is troponin that is elevated. In the context of this, what kind of MI? Is it MI? I am not saying it is not MI. What kind of MI it is? It is type 2 MI. And which is liable to angiography and improvement? Type 1. Someone Maran, are you understanding? Clear? Type 2. So if there is occlusive type 1 and type 2, there is non-occlusive also. What is non-occlusive?
Partial or complete occlusion with revascularization of
No, what is non-occlusive? When you say non-occlusive, non-occlusive. You cannot have partial. Non-occlusive. Yeah, sepsis. You have patient of sepsis. Patient has got sepsis. Patient heart breathing like super fast. He does not have any cardiac problem. He does not have anything. No plaque, nothing, no rupture, nothing. But his heart is beating so bloody fast. So bloody fast that his heart is beating. That it is that where you cannot maintain the demand versus the supply. For example, you have got severe hyperthyroidism. Hyperthyroidism, the heart is beating super fast, atrial fibrillation, fast ventricular rate. Okay, there is nothing wrong in the heart. Inside there is no plaque, there is nothing, there is no occlusion. But the blood supply, the beating of the heart is so much that the existing blood supply is unable to provide the heart anything. And this is what is the biggest issue in intensive care. When you have a patient of sepsis and you send a troponin that comes out to be positive, that usually is non-occlusive MI. So you have a patient of sepsis. Who comes to you tachycardic, very tachycardic. Okay, you see this patient in the ICU. You say tachycardic, he's breathless. This should be MI. Let me send a troponin. Troponin comes positive. What am I dealing with here? It's non-occlusive. He does not have typical chest pain. That's why the typical chest pain is very important. Don't look at a pulse rate and say there were small changes and so I do it. Where am I going to intervene? I am going to intervene only in this. Is there a point of sending troponin? No. Then you send a troponin, comes out with positive, and then you don't want to do with it. Are you understanding? Clear on this? Am I clear on this? So non-occlusive MI will occur in a patient who does not have any problem, and this is classically seen in ICU, where you have out of the, if you now take patients in the ICU and you take troponins of 8 of them out of the 10, okay, or if you take troponins of all of them who are really ICU patients, 8 of them or 5 of them will have troponin that is elevated. You understand? 5 of them will have troponin that is elevated. It is going to occur. It is going to be there. Or there is going, but they are not myocardial infarctions of occlusive nature. That doesn't require anything per se. Clear? Am I clear? So the context is very important. The context is very important. That's why troponin is a fantastic investigation, provided done in the right context. Provided it is done in the right context.
So for type 2, then we don't send troponins if we don't have ECG changes or pathologic Q waves. Then
for type 2?
For type 2, then we don't want to send troponins.
You may want to send it just to diagnose NSTEMI, no?
NSTEMI, not for
Non-STEMI or angina.
You are going to, so what we know is STEMI and NSTEMI, right? So for NSTEMI, I want the MI, I want to send it. Okay, I want to see there is okay. But it's not that I am going to do an angiography for that. Are you understanding? Where am I going to do an angiography? Here.
Immediate intervention.
Immediate intervention. You understand? So that is why if you have got typical chest pain and you have got ST segment elevated, do we wait for troponin? No, we send them to PAMI. You understand? If you have ST segment elevated and you have typical chest pain, we don't say let the troponin come. We say send them directly to the cath lab for PAMI. Are you understanding? So you need only one of these. You don't need troponin specifically. You don't need echo specifically. You don't need this. You need any one of these. If tomorrow patient comes has got typical chest pain, I do echo, I see a digital mouse, that is new. I know earlier it was normal. If I know earlier it was normal and this is new, I would say, boss, this patient needs an immediate angio. In the ICU, you have a patient who's come for something else. He's come for something else. He has come for THR. He's come for total hip replacement. You have done a total hip replacement. And now, next day morning, he says chest pain. You do an ECG. ECG is normal. You do a troponin comes positive. Oh, this is probably going to be occlusive MI. I need this patient to go to cath lab quickly. Are you understanding? You have a patient post THR comes to you. He's got typical chest pain. You do a troponin, it's negative. You do an ECG, it's negative. You do an echo. That shows response abnormality. What is this? MI. Send in for PAMI. You understand? So when you have chest pain, the evaluation should involve all of these. Specifically thinking about this segment, not this segment. You understanding? Thinking about this segment because this is something that requires to go quickly to theatre.
So, but in diabetic patient, many times we don't get a typical chest.
You will not get. So they are outliers. They are outliers. We don't know what to do with those patients. There you require it. That's why all of these things are done with the opinion of a cardiologist. We don't do it on our own. All of these things we discuss with a cardiologist. The cardiologist knows exactly what we do. That's why he's a cardiologist, right? So we discuss these things with the cardiologist. Patient has typical chest pain or atypical chest pain in certain conditions. You'll probably discuss. Then you'll require all these things. That's why we do not one investigation. We don't just say that send a troponin and say, okay, let the troponin come. We're doing ECG. We're looking at echo. We're, this is what we're doing, isn't it? You understand? Clear? Clear? Any doubts here? Okay. Now, when it comes to the treatment of this we are clear. Okay. Now, Ashok, you have a patient that comes to you. He has got a situation where he has got chest pain and he has got troponin that is elevated. What is the next thing you will do? You want to go to this condition, right? So, what is the next thing you will do bedside? What are the pharmacotherapy that you use? I agreed we did ECG. ECG on myocardial infarction is a very big topic. I can't do that now. It's a huge topic. Okay, it's a huge topic. Okay, when we come to ECG, we'll talk about that. But you will do an echo, right? So in an echo, when I say troponin, you understood. It is going to be above the 99th percentile of upper limit of normal. That's what we have. What we are showing over there, 99th percentile. what हमको जो दिख रहा है वहाँ पर जो values दिख रहे हैं, that is 99th percentile, right? So if it is above the 99th percentile of the upper limit of normal, we are considering that to be positive. We have understood what is dynamic rise and dynamic fall. ECG, we will discuss that on a later date because it's a very large topic, ECG and myocardial infarction. We will discuss that on a later date. But ECG. Third thing is echo. Echo is very simple. Echo is you have a heart. First you look at a short axis view. You look at a short axis view. So this entire area becomes left anterior descending artery. Right? This entire area becomes left circumflex. Always say LAD, LCX together. One after the other, you see. And then you say the PD and LAD to be LCX plus RCA. Simple. So in a short axis view, you always say LAD, LCX. And this territory that you see over here is PDA, that is LCX plus RCA. We are going to talk about the three arteries: LCX, RCA, and LAD. When you look at MI is not difficult. Echo में ऐसे कोई major कुछ नहीं चाहिए हमको. You just have to look at this view. Okay, if you are looking at this view, we see LAD territory here. We see this is called as what view? Short axis view. In the short axis, we are looking at LAD, we are looking at LCX, and we are looking at LCX plus RCA. So if you have here, it's LCX region. If it's here, it's LCX plus RCA. If you see here, it's LAD. Clear? Then the other view that you can look at is the long axis view, right? Right? So where is LAD here?
That part below.
Which part?
The lower.
This entire area is LAD. Okay, this entire area is LAD. You have LCX and you have PDA. Clear? ये हो गया long axis. Then you come to two chamber. You have only two chambers. Two chambers. You have two chambers. Okay. When you come from four chamber and you turn, it becomes two chamber. In two chamber, what happens is you are showing one entire part as LAD and one part as PDA or RCA plus LCX. LAD and RCA plus LCX. Simple. Clear? You don't have to do anything more than this for echo. इससे ऊपर कुछ करना ही नहीं. हम लोग को ये व्यू निकालना है और देखना है. व्यू निकालना है, बाकी कुछ नहीं करना है. Simple. Any doubts here? Simple. This you have to memorize. इसका कुछ नहीं कर सकते. इसमें memorize करना पड़ेगा. We are not looking at inferior basal wall, posterior wall, lateral. So ऐसा सोच ही नहीं रहे. हम territorially सोच रहे हैं. As intensive के doctors हम territorially सोच रहे हैं कि LAD territory है क्या, LCX territory है क्या, LCX plus RCA है क्या. That's what I'm looking at. You understand? So don't put your head on the side कि inferior wall है कि posterior basal wall है कि inferior lateral. नहीं, हमको सोचना ही नहीं है वैसा. हमको वैसा सोचना ही नहीं है. हमको क्या सोचना है? Regional wall motion abnormality है कि नहीं? By territory. समझ में आ रहा है? Clear? If there is fresh regional wall motion abnormality, you are looking at myocardial infarction. This is what you are looking at. Simple. Keep it simple. Okay, keep it simple. So when you are doing, देखो कि ये कौन सा territory है, ये कौन सा territory है, ये कौन सा territory है, रखो ये कौन सा territory है, ये कौन सा. Every patient you do. Four chamber में ऐसी very similar it is. LAD full, septum में RCX, LCA and PDA. Simple. It is the same thing. You always say LAD, LCX together. So whenever you are talking about LAD, you say LAD and LCX. And बच्चा जो रहता है उसको हम PDA बोलते हैं. समझ में आ रहा है? Clear? Same. So four chamber will be like this, like this, like this. Okay. So you have LAD, LCX, PDA. Simple? Yeah. LAD, LCX and PDA. Okay. Simple. So it's all simple. It's all very, very simple. All you need to do is just memorize this. Okay. It's very simple. Clear? Echo. So now we are aware about echo. We are aware about dynamicity of troponin. ECG, it's too much. It's too vast to actually explain to you ECG now. It's too much. Okay. So now you have this patient in front of you who had this problem. What are you going to give this patient? Patient is saying just pain.
Patient come to me with severe chest pain. I just first assess the patient.
Assess. Vitals are done. BP is fine. Pulse rate is fast. Pulse rate is 120. So in your assessment, what are you looking at?
Patient has severe chest pain. So because of pain, patient have fast
What are you looking at? So what are you looking? Okay, fast. Okay, fair enough. Go ahead.
So I'll give anesthesia. Actually give morphine or fentanyl.
So you want to give analgesia?
Yes.
No, but how do you assess? Forget the what you're going to give. What are you assessing? इसमें क्या देख रहे हैं आप? Patient आया तुम्हारे सामने. इसमें क्या देखने वाले? I am saying a simple case. Patient आया तुम्हारे पास. Chest pain आ रहा है. Patient is having chest pain. You have already done an ECG which shows some changes on the ECG which is looking towards MI. You are patient is in front of you very clearly. Pulse rate you're finding is 120. I'm giving you an example of the classical case, this yesterday's case, 12 number. 130 pulse rate hai. And his blood pressure is 100 systolic. Okay. Now this is what you have vitals. Now what do you do? How do you assess? इसमें assessment क्या कर रहे हो? आपने ये सब तो assess कर लिया. Now you have to assess. What are you going to assess? You're going to assess about whether this patient is in failure or not. You understand? So if you have an MI, you're going to assess whether there is failure or not. That is where your echo is coming and that is where your auscultation is coming. That is where your echo and auscultation is coming. You're understanding? You're understanding? So when you're assessing this patient, this is not the end of the story. I have to now grade it into 4 grades. Which are the grades? MI. Which is the classification? Class of MI. But when you have an MI, and you have to grade it. Class 1, class 2, class 3, class 4. Have you heard of Phillips classification?
Failure is.
So this is very important. This is extremely important in every case that presents into the ICU with MI. Okay, where class 1 is there is no dyspnea, there is no crepitation, there is no failure, there is nothing like that. Class 2 is there is some amount of dyspnea, but there is no failure pattern as in crepitations and all these things are not there. Class 3 is there is overt respiratory failure, which includes dyspnea and the presence of B lines on your ultrasound or crepitations on lung failure or crepitations on auscultation. And class 4 is there is severe pulmonary edema with hypotension. So you have class 1, class 2, class 3, class 4. Where is our patient? Yesterday's patient?
Class 3.
Class?
He came in failure with bilateral crepitation.
But did he have hypotension?
Hyper, he was hyper. ETG was there.
So what was it?
3.
Class
3.
Class 3. So because you are not writing it on your paper, no, you are not remembering. समझ में आ रहा है? अगर तुम लोग ये पेपर पे लिखते तो तुमको ये याद करना पड़ता क्या? So what should have been your thing, sir? Patient has come. He's in Phillips class 3. I have found that he does not have typical chest pain. He didn't have typical chest pain. He didn't have typical chest pain. ECG does not show any typical changes. Regional non-motion abnormality is not there. Only troponin is there. Is that MI? No, yeah. It's not even MI. It's like type 2, maybe type 2 plus or something like that. You understand? Clear? But this is important for me to know. No? Class 3 or class 3 is important for you to know. Because now, why is this important for you to know? Because many of the treatments that you're going to do is dependent on this class. Many of the treatments you're going to do is dependent on this class. Clear? So this is a Phillips class 3. That patient is in Phillips class 3. Clear? Clear? That is your first assessment. Second assessment is something called as shock index. That is heart rate divided by systolic blood pressure. Let's take this patient. Okay, he was 130 and when he initially came, his blood pressure was 100. Then it went up after some time. Then after some 1 to 2 hours, blood pressure we found was elevated. We decided to, or was it, how much was it? 120? What was it? 120 blood pressure? Let's put 120. Divide 130 divided by 120. He came with the pulse rate was fast, 126, 124, 118, something like that. What was it? 180? 120? Someone told me the pulse rate is fast. बराबर ना? कल का जो पेशेंट आया था 118 या 120 उसका पल्स रेट था, right? So let me put 120. Let me put it 120, right? That is the reason that somebody came and added carbidiol, no? Pulse rate was fast, right? So 120 divided by 120 is 1 more than 0.8. If the shock index is more than 0.8, this patient is not okay. This patient is not okay. Are you understanding? Understanding? So So your assessment should have had the shock index, which actually says that the heart rate divided by blood pressure. I'm going to assess my heart rate. I'm going to assess my blood pressure. If my heart rate divided by blood pressure is more than 0.8, I'm worried. Clear? Then what is the next assessment? I'm giving you one more idea. The blood pressure of this patient was 120/90. Now tell me. Sorry? Sorry? Come on, Ashok. Next assessment. Huh? Pulse pressure. What are you concerned with the pulse pressure? Come on, tell me right. Tell me why. Pulse pressure, not mean arterial pressure. Pulse pressure. No, not mean arterial pressure. You don't look at mean arterial pressure. You're not in that perspective. We are still in the condition where we are judging cardiac output. We are judging cardiac output here, right? So if your pulse pressure is less than 20% of your systolic blood pressure, if your pulse pressure is less than 20% of your systolic blood pressure, the chance of you having a normal cardiac output is less likely. The chance of you having a normal cardiac output is less likely. Understand these words very carefully. If your pulse pressure is less than 20%, so let's take this patient's as 60, 120/60, or 120/90, 90 forget yes, not 90. So 120/88 or something it was. So 120 divided by 90 is how much? 30. That is your pulse pressure. 120 minus 90 is 30. That's your pulse pressure, right? Now what is systolic blood pressure? 120. What is 20% of 120?
24.
24. It's not less. But if it was lesser than that, if it was say 120/98 or something, we are looking at a low cardiac output. Pulse pressure. Clear? Clear? So pulse pressure becomes important. So now that we have gone through all these things in this particular patient, we have gone through all this. Let's take the same patient. Okay, and now I know that this same patient in our ICU has got crepitations. He had crepitations. We did a ultrasound which showed multiple confluent V lines. Okay, and he actually presented with a breathlessness. Okay, I put a classification as Phillips class 3 on this particular patient. What is my next echo thing that I will do here now? Now that I have understood this, what is the next echo thing? I will do two things. I will look for aortic regurgitation, because when I do echo, I am going to look for aortic regurgitation and mitral valve. Two things I am going to look at: mitral valve and aortic valve. I am going to look at aortic valve, I am going to look at mitral valve. That is exactly what Dr. Ambadekar did, no? What did he come and do? After doing regional wall motion melody, the next thing what did he do? He looked at aortic valve, he looked at mitral valve, because that is the usual protocol. You look at aortic valve, you look at mitral valve. You don't end at regional wall motion abnormality. Okay, why? Why is that so? Because if a patient has got chest pain and if the patient has got failure pattern, you need to rule out aortic dissection also. Aortic dissection can present with severe aortic regurgitation. It can present with aortic root dilatation. Right? If you have chest pain and you are present with failure, that is Phillips class 3 and above, you can have myocardial infarction causing the mitral valve to get disrupted. So mitral regurgitation can occur. You understand? This is not Phillips class 1 or class 2. You are at Phillips class 3 and class 4. Apart from failure from just functional activity of the heart, we have to look at aortic regurgitation. We have to look at mitral regurgitation. We have to look at ventricular septal defect. Three things. You understand? So when you are doing Phillips class 3, class 4, patient is in failure, these three things have to be looked at. That's why I said that Phillips class becomes important. That Phillips class becomes important. You understand? Once you go to Phillips class 3 and class 4, you are looking at mitral regurgitation, aortic valve regurgitation, aortic root dilatation, and ventricular septal defect. You understand? That's why auscultation becomes very important, ECG becomes very important. If you do an ECG, you may find some features that look like that. If you find an ECG that shows clear regional wall motion abnormality, I am okay. Yeah. I know this is probably MI, and I will just rule out the complications which are mitral regurgitation, which will cause sometimes mitral valve prolapse or mitral valve regurgitation, something like that. But if I am having a patient who is having ECG that is only showing ST segments that are depressed in 3-4 leads, and is a failure, I need to rule out these three sinister problems. You understanding? That is why I need to look at the aortic valve, mitral valve, and ventricular septal defects. Clear? Because this is common typical chest pain. Simple? The algorithm is simple? Clear? So now my assessment is near about complete. Now my assessment is near about complete for my emergency purpose. Are you understanding? For my emergency purpose, now my assessment is near about complete. Okay, I am going to wait for my cardiologist to do an angio if required in this patient, and in that patient I don't require. No, in our patient we don't require now. Are you clear? In our patient we don't require an angio urgently. We don't require that. We are clear on that. Are we all clear? In our patients that we don't require angiography. Clear at this moment. So what do I do next? We are not requiring emergency. We require the future, but not emergency. Then what do you give? You want to give something. He has got chest pain. He's got chest pain, and he has got tachycardia, which you are saying. What are you going to do? So there again you must understand Kilip's class. Okay. So once you are in Kilip's class 3 or Kilip's class 4,
Beta blockers
is not supposed to be given. Beta blocker are contraindicated. Class 3 and class 4, even if you have pulse rate that is fast, it is completely contraindicated. So we don't want to hear this when you are an ICCM student. Because when you say something like this, then we directly fail. That's a direct failure. Okay. So because this is not supposed to be done at all. Okay. So beta blocker you are not supposed to give when on Kilip's class 3 or class 4. And why is that so?
Lungs are already composed.
So no, not bronchospasm. This is so bad, this patient's cardiac output is so bad that is causing failure, and on top of it you are giving a negative inotrope.
Again,
It is again going to cause problem. This person's heart is so bad that it has caused failure, no? Kilip's class 3 and class 4 is failure. So when you are having so much of failure, class 3 and class 4, that the heart has got filled up, the heart is not able to contract, it is causing LV failure. You are giving a negative inotrope at that time. I don't want to give it at that. I want to wait for the heart to get a little bit better, in short decongest the lungs a little bit better. I want to give it, but not now. Clear? So it's not beta block. Chest pain is going on. Chest pain.
morphine.
So no, don't give analgesia. Try not to give analgesia. Why? You will mask the symptom. Try not to give it. You may mask the symptom. This patient needs to go quickly. His chest pain will go, the seriousness of the situation will go down. And this is in emergency we're talking about. But what do you need to give there?
Oxygen.
What is the drug you give? What is the drug you give when you have MI?
Sorbitry.
When you have MI, what do you give? What do you give when you have MI? What is the first drug you give?
Aspirin.
Aspirin, no. Aspirin is the first thing you give, no. The first thing you want to give is what? It's going to take a while to work. Give the aspirin quickly. That is the first thing you think. Chest pain hai kuch bhi ho. Because when I first time asked you, you had chest pain, what do you give? You said opioid. I give thuen. No, my first thing is aspirin. My first thing is what? The only drug that is actually convincingly proven to actually reduce mortality and major adverse cardiac event in the history of myocardial infarction is aspirin. So aspirin needs to go in. Simple. How much does it need to go in? 325. So how many tablets?
Non-coated single.
75 का कितना tablets हो गया? 4 plus. So it can be 4-5 tablets. 300 plus देना है. ठीक है? 300 plus. Clear? Clear on this? So that's why you need to give aspirin the first thing that you do. Clear? Next drug. So what are the drugs you have? You have pasugrel, you have clopidogrel, you have ticagrelor. How do you decide that?
Cardiologist. If he is taking directly to the cath lab, the brilliant cardiologist prefer this ticagrelor.
And what will you tell the cardiologist?
He will decide.
What should you tell? You have to give some important history to the cardiologist. What is that history? So you will give a history that says that this patient has no high bleeding risk.
Okay.
It's a very important history that you give a cardiologist. Okay, that this patient is not on oral anticoagulants. This patient is not having high bleeding risk. Two very important histories. And third important history is what? Patient does not have bradycardia. There are three important things that you need to say. What are the three important things you want to say to the cardiologist? Once more, no high bleeding risk. Like for example, if this patient 1 month ago had a bleeding pile or had a bleeding ulcer, you have to tell this to the cardiologist, because that is a time that I am not going to use these difficult agents like ticagrelor. I may even omit clopidogrel for that matter. You are understanding? Clear on this? Clear? Huh? So I am not going to use it. So I am going to explain about the high, if there is any high bleeding risk. If there has been a stroke in the past, because if there is a stroke in the past, prasugrel is contraindicated. If there is a stroke in the past, prasugrel is contraindicated. Third, I am going to talk about oral anticoagulants. And fourth, I am going to talk about bradycardia. Right? So in bradycardia, I can't give ticagrelor. So if it's 30 and 20 pulse rate, I can't give ticagrelor. So these are the four things that I am looking at. When you say Brilinta, it is ticagrelor. Okay? Right? Of course, this has to be discussed with the cardiologist. And then you say, sir, whatever you discuss, this is the history that you are going to take. Right? On the pharmacology. You will tell the cardiologist, okay, this patient does not have any of these things, so let's give ticagrelor. How much you give?
180 milligram stat.
And 90 BD after that, right? That's what we're going to do. 180 milligram stat.
So none of these are there, then ticagrelor is the preferred drug over clopidogrel.
Good question. So if it was my uncle, if it was your uncle, what would you give? You'll always do the right things for your own relatives, right? So what do you want to give? Clopidogrel or ticagrelor? Come on. And why? So you have both the options in front of you. You have to have both in front of you. This patient is there in front of you. Clopidogrel or ticagrelor? What will you give? Cardiologist of course I will ask. There's no doubt about it. But what will I give? If the cardiologist phone nahi laga, I will ask. Why? There has to be some reason. So I'll explain to you that. So you should understand what is the difference between both of them. Okay, it's very essential that you understand what is the difference between both of them. Now, when you give clopidogrel, let us see clopidogrel versus ticagrelor, right? You nowadays hear many of the surgeons talk about ticagrelor again and again, right? They don't talk about clopidogrel. Why? Because when you give ticagrelor loading dose, you achieve levels in 2 hours. You achieve levels in 2 hours, quite quick. When you give clopidogrel, the levels are achieved somewhere around 6 hours. When you give clopidogrel, the level you achieve is somewhere around 6 hours. Clear on this? Clear on this? There is no change in mortality when you compare to aspirin, both the drugs. Both the drugs, mortality difference is not major. You understand? Aspirin जैसे mortality difference हो रहा है, you know, there's a 2.4% reduction in mortality in 5 weeks. That kind of mortality difference is not there when you look at clopidogrel and ticagrelor. That kind of mortality difference is not there. But the bleeding risk is higher in ticagrelor. Bleeding risk is higher in ticagrelor. Okay. But this ticagrelor actually caused reduction in re-hospitalizations, reduction in repeat acute coronary syndromes higher than clopidogrel. Okay, it reduced the reoccurrence of acute coronary syndrome, reoccurrence of re-hospitalization as compared to clopidogrel. Clear on this? Clear on ticagrelor? Clear on this? Another thing, what is important about clopidogrel is that clopidogrel is metabolized by a pathway called as CYP2C19. CYP2C19.
Drug interaction.
So there are drug interactions that come with clopidogrel. And also if you don't have the CYP2C19, what is this drug going to do? If your level of CYP2C19 is different, it is going to metabolize differently. Not convincingly you know that what is going to happen. Right? Not convincingly. Unlike ticagrelor, which does not follow the CYP2C19 metabolic pathway. You understand? So now, given your relative, what will you give? I can't explain this again. But what about the rest? What is your, how are you going to die because of what?
Rehospitalization.
You're going to die because of what? Because of MI, right? What is going to achieve faster? You understand? Right? Clear on this? Understood the difference between clopidogrel and ticagrelor? Huh? So if I want to give ticagrelor, we call the dose. What about clopidogrel?
300 standard.
So it's 300 to 600. It's 300 to 600. And we know that if you give 600, the attainment of level is much faster as compared to 300. So I will not be wrong if I give 600 milligrams of clopidogrel. Recorded aspirin in the ER. Understand?
And what to do, sir? Patient is already on dual plated. Whether to give loading dose again?
No, not required. No,
Just
not required. It doesn't make a difference. So you may want to give a loading of clopidogrel maybe, but we know that this doesn't affect long-term mortality. You understand? So now next drug.
statin.
Anticoagulant. Okay, so which anticoagulant? So the drug that I want to give first, remember, is aspirin. Okay. This next drug I want to give is not Clexane, it is clopidogrel or ticagrelor or pasoglor, whatever. Okay. And the next drug I want to give, the last drug I want to give is actually statin. Statin is my last drug. 80 milligrams of statin. So these are the things that you should give. Right. Then the fourth drug I want to consider giving is going to be anticoagulant. Right. The fourth drug I consider giving is anticoagulant. The first three drugs are what? Aspirin, clopidogrel, and atorvastatin, where I will even take off clopidogrel if you want. Aspirin, atorvastatin. Very, very important. Then I want to consider an anticoagulant. Okay. And what is the anticoagulant I'm considering? Which is the enoxaparin? No. The anticoagulant of choice is
Heparin.
fondaparinux. The anticoagulant of choice as per guidelines for non-ST segment elevated myocardial infarction or MI is fondaparinux, and the dose is 2.5 OD. That is the dose you're supposed to give unless the creatinine clearance is less than 20. If the creatinine is less than 20, I can't use fondaparinux. Otherwise, fondaparinux is my drug of choice as per the OASIS trial in myocardial infarction. Unless the cardiologist doesn't want to give it. Sometimes what happens is why the cardiologist doesn't want to give it, it doesn't inhibit the prothrombin. It doesn't inhibit the prothrombin, fondaparinux. So the cardiologist later on has to give heparin. When you give fondaparinux, the cardiologist intra-op will give heparin. You understand? So when the cardiologist needs to know what kind of anticoagulation you have given, because in the event that he you give fondaparinux and he doesn't give heparin, early stent thrombosis is high. You're understanding? You're understanding? Because this is not the problem with Clexane. So why not use Clexane for that matter? Because it has been proven in many studies, in a few studies, large studies, that fondaparinux reduces major adverse cardiac events in the future. That is why fondaparinux is a drug of choice in these cases. Clear?
Sir, repeat it once again.
What has been proven is it is not dissolving anything, but it prevents major adverse cardiac events in the future. You understand? Major adverse cardiac events in the future. That is why fondaparinux is a drug of choice as per all major guidelines. As per all major guidelines. It's class 1 recommendation. There is a recommended Clexane also, but it is lower than fondaparinux. Okay? Unless contraindicated, it has to be fondaparinux. Of course, all of these statements, that I said, aspirin, clopidogrel, atorvastatin, fondaparinux, has to be discussed with the cardiologist. Okay, it has to be discussed with the cardiologist because all of these things are taken with respect to what you're going to do in the future. You understand? For example, let me explain to you. You have a patient who comes in with typical chest pain, has got an AVR that is elevated, and has got T-wave inversions everywhere else. What are you looking at? Sorry? Exactly. Okay. Once you have an ECG that shows that the patient has got typical chest pain, so I'm near about certain that this is probably an MI, and I just need an ECG finding. I do an ECG finding that shows T-wave inversions everywhere, and an AVR that is ST segment that is elevated. This is probably going to be left main occlusion. If there's going to be left main occlusion, my cardiologist might say, let's not give clopidogrel. Why? Because this patient will go for surgery. This patient may go for bypass. I'll shoot an angio and see, and this patient might go for emergency bypass surgery. So if there's emergency bypass surgery, I don't want this brilliant on board causing so much of bleeding. I don't want this clopidogrel on board, which will take a long time to reverse. Are you understanding? So that decision you will have to discuss with the cardiologist. So you have to discuss this with the cardiologist about what I'm going to use apart from aspirin. Clear? So there are many such instances where probably that's why the discussion is required. For example, you do an ECG, it shows ST segment that is elevated, but has been elevated for last 15 days. Cardiologist will probably know that. Okay, it might be LV aneurysm. I don't want to do anything here. That's different from what. So the chest pain is related to pneumothorax or something else. It's not. So at that time you give an anticoagulant, it probably does rupture. Steroid is only rupture. Understand? So you must think like this. So that's why discussion with the cardiologist is very important, because they are they are specialized in this. But this is the basic you must know. Where does beta blocker and ACE inhibitor fit now? Now that you did talk about beta blocker, the first thing. So where does it fit now? Where does nitrate fit? All of you have talked nitrate, all of you have talked beta blocker. Where does these things fit? So nitrate का role क्या है? Sorry? So what is so when do you give nitrate? When he's having angina pain. Yes. So the answer is when there is angina pain, I require NTG. That doesn't mean that if NTG cures the anginal pain, this is MI. No, that is not right. To assume that NTG की वजह से उसका pain गया, that is why this is MI. No, it can cure. MI is transmural infarction. Angina is just pain reduction, demand supply. Ischemia. Got a point? There's difference. So for a chest pain, I will want to give nitrate. Clear? For a chest pain. Which other case I want to give nitrate? Yesterday's patient? Killips class
3 and above.
Killips class 3 and above. Which other patient I want to give nitrate? Yesterday's patient went into hypertension. So there are clear-cut indications for NTG. The indications are if there is ongoing chest pain. Second thing is if there is Killips class 3 and class 4, you don't need to have chest pain, you don't need to have hypertension. Killips class 3 and Killips class 4, I want to give NTG and hypertension. There are 3 indications where I want to give
hypertension.
Hyper.
Class 4.
Class 3. Not class 4, sorry. If there is hypertension, no. Class 3. Okay? Failure pattern basically. Class 3. Clear? Class 3. That's failure pattern. Clear? Clear? Where are not? So since there is where you can use it, there is somewhere we should not use. Very important, because the other day someone used it and I had to speak to the cardiologist later on and tell him about all these things. Right ventricular myocardial infarction. Right ventricle. So if there is right ventricular myocardial infarction or inferior wall myocardial infarction, without the cardiologist, you should never start NTG. Without the cardiologist discussion, you should never and never start NTG. Irrespective of whether he has failure, irrespective of whether he has hypertension, irrespective of whether he has chest pain, you will never start NTG if this patient has got right ventricular myocardial infarction. Clear? Or inferior wall. Now you know that in that distribution, inferior wall will have LCX and PD. It can be pure right ventricular myocardial infarction also. So that we will discuss with the cardiologist. NTG. Where else will not use NTG? Where else? So we are looking at 2 valves, right? So which
Aortic one.
aortic stenosis. So that is why we have to look at the valve. अगर तुमने valve नहीं देखा है, valve में stenosis है, तुमने NTG, the patient will crash. Patient will crash. You understand? Clear? So if you have right ventricular myocardial infarction, how do you understand this? Patient will have JVP that is distended, lungs will be clear, and patient will have chest pain. That is our right ventricle. That is right ventricle. You understand? In that case, if the right JVP is raised, chest is clear and there's got chest pain, inferior wall is there on an ECG, this is what? RV. If there's RV, I don't give NTG. Simple. Okay? So NTG, I will not give when there is RV. I will not give when there is aortic stenosis. Clear? So I will not. That is why when you are doing the echo, it's important to look at not only the regional wall motion, it is also important to look at mitral valve and aortic valve. There are various reasons why we do each of those things and everything is interrelated. Everything is interrelated. You understand? Huh? Clear? Clear? You clear about when to use NTG, when not to use NTG? Clear on this? What about beta blocker?
Class 1 we can do.
Class 1, class 2.
Class 2.
When?
Tachycardia.
Patient has burst
Irrespective of tachycardia, irrespective of high blood pressure, I would want to start beta blocker within the first 24 to 48 hours because it changes mortality. Right? So I would want to. So my question should go to my cardiologist. Sir, shall I start beta blocker? Shall I start? That is why Yatin, what did he do? He wanted to start that quickly, carvedilol. You understand? Within 24 to 48 hours, we want to start a beta blocker. It is sine qua non. We want to do that. Right? Clear on this? Beta blocker. Where you will not start?
Class 3 and class 4.
Class 3 and class 4. I don't want to start beta blocker when there is class 3 and class 4 and pulse rate.
Bradycardia.
PR interval 240 milliseconds. Okay, so you have 3 places where I will not use it. One is there is bradycardia less than 60 pulse rate. Once there is a PR prolongation that is more than 240 milliseconds. Okay, and when there is Phillips class 3 and class 4. I will not be using my beta blocker. You understand why you should have Phillips class now? Without that, how can you formulate your plan of action? It's very difficult, right? So whenever you have an MI, this thing should be there in your notes, right? You don't need to study these things. These things as a theoretical, so you don't need to study. It's there. If you do it daily, you don't need to study. It's just there, right? Then what about ACE? That's another very important thing. ACE and ARBs, right? ACE inhibitors. Where do you give that? All patients who have got EF of less than 0.45, EF of less than 45%, warrants an ACE inhibitor. Warrants an ACE inhibitor. Okay, and when that should be given? Within 24 to 48 hours again. Okay, in which patients you will not give it? When there is bilateral renal artery stenosis. Okay, when the patient has incessant cough, when the patient has got renal failure, when the creatinine is elevated. These are the patients we will not give ACE inhibitors.
Irrespective of his hypertension history, no. Just for cardiac remodeling, we are using.
Yes, it's supposed to be very good. So what you will not give in these cases? Which drug you will not give? Non-steroidal anti-inflammatory drugs. This is something that you will not want to give because whatever effect you want to see with beta blocker and ACE inhibitor will be inhibited by NSAIDs. It will prevent this remodeling from occurring. It will prevent whatever importance you want. So that's why you don't give a non-steroidal anti-inflammatory drug at any moment when you have a myocardial infarction. Clear? So we don't give NSAIDs, right? What is the last drug which we use? Oxygen, right? So when do you give oxygen?
Patients are less than 94.
93. So anything 93, 90 less than 93, 94 we probably less than 93 we probably want to start oxygen. Clear? When do you want to start this morphine and opioids? When all of this has started working and the chest pain is not gone. You may want to do this, but believe me, when you have a chest pain from myocardial infarction origin, thuen, morphine, all this will not work. Okay, it will not work because it is extreme chest pain. You can't take care of it. You may want to give whatever you want to give, but it generally doesn't work. Yeah? Any doubts?
Sir, about thrombolysis, if it's not possible, just
about
if thrombolysis
is
if it's PAMI is not possible, so thrombolysis.
It's out of that window period.
So within 12 hours, if you have a patient who is having chest pain, hypotension, there is no PAMI available, you may still want to try thrombolysis. Though it has to be 90 minutes, you may still want to start thrombolysis. But for that, you have to first put the box in place that this is MI. You have to put that this is type 1 MI of the occlusive variety. Then you have to put this in place that it does not have any other problems that preclude thrombolysis or fibrinolysis. And then you have to take the thrombolysis. Here, once the window, beyond the window period, you can't do anything.
So, any other importance of shock? Like you're saying, shock index is more than 0.8. This patient is bad, but any other importance?
No, the cardiac output is low. No? When the cardiac output is low, you can't do many other things. No? You can't keep beta blocker, you can't do so many things. You can't keep beta blocker, you can't do ACE inhibitors, you can't do many things with this patient. The patient's prognosis is bad. His prognosis is bad. That's why it's important. Look at that.
And rescue family should be done within.
We are not in PAMI yet. PAMI में किया ही नहीं है. ये खाली हम लोग before PAMI तक पहुँचे. PAMI तो लंबा है. अभी प्रॉपर से PAMI तो लंबा है.
Class 4 can
So that is completely different domain only. Class 4 is cardiogenic shock, is a different topic. Class 4, we are in MI, just basic MI. Cardiogenic shock we have done in the past. I think you did it, cardiogenic shock. Someone did it. Who did cardiogenic shock? Someone did cardiogenic shock. Who did it? You did the cardiogenic shock. It's a completely different topic only. When did you do this cardiogenic shock?
Long time.
So let's do it next time. Again, because I don't think people have kind of forgotten. I think so. ठीक है?